Welcome to the She Found Motherhood podcast. We are doctors Sarah and Alicia, maternity physicians and moms who have been through it all. We want to empower you with knowledge so you can have the best pregnancy, birth, and postpartum experience you can.
She Found Health and She Found Motherhood is meant for general medical information only. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. This information does not apply to every situation. If you have questions or if you've received different advice, please contact your healthcare provider. Always seek the advice of your physician or another qualified health provider with any questions you may have regarding a medical condition. The views expressed by She Found Health and She Found Motherhood and our guests are not representative of any of the institutions with which we are affiliated. Some of our podcast episodes are sponsored so that we can keep getting great info out there to you, our listeners. We only partner with companies that we truly believe in. Some of our links and suggestions may be affiliates, and we would appreciate you using them to help fund this important work. Now let's get to it.
Alicia, are you excited to talk RH factor?
You know it. Let's get into the good stuff.
All right. So RH, or rhesus factor, is a protein or antigen that is present, or not, on your red blood cells. When you get your blood type checked, in addition to the type, A, AB, B, or O, there is also a plus sign or a negative sign associated with your blood type. And this refers to the RH factor. An individual who is Rh positive has the Rhd antigen on their red blood cells, while the person who is Rh negative does not have the Rhd antigen on their red blood cells.
There are certain populations that are more likely to be Rh negative, and these include those of Caucasian descent, so about 15 to 17% of people, African descent, about 4 to 8% of people. Individuals of Indian, First Nations, Inuit, and Asian are less likely, so less than 5% of the population to be Rh negative.
So why do we care so much about this tiny little antigen in pregnancy? It's complicated, and we will try to explain it as best we can. If a pregnant person is Rh negative, and they are exposed to Rh positive blood cells, then their body actually makes antibodies against those Rhd antigens. This exposure can happen if an Rh negative woman or pregnant person is pregnant with an Rh positive fetus and is exposed to fetal blood during pregnancy and birth. This exposure can happen through a number of different events, including delivery, both vaginal and cesarean section, during miscarriage, if the pregnancy is beyond 7 weeks or so, during any antepartum hemorrhage, so bleeding during pregnancy, a trauma, like a motor vehicle collision or a significant fall, procedures like chorionic villus sampling or amniocentesis, if there's an ectopic pregnancy, meaning a pregnancy outside of the uterus, or molar pregnancy, which is a very complicated pregnancy we won't get into here. There are other non-pregnancy related exposures that could potentially happen as well, but these are much less common, and these include blood transfusions, bone marrow transplantations, and needle stick injury.
So what happens is that the D antigen present on the fetal cells is not recognized by the Rh negative pregnant person's immune system and is instead seen as something foreign, like a bacteria or a virus. The immune system, in its intelligence, then makes anti-D antibodies, which can bind to those D antigens on the red blood cell of the Rh positive fetus and break down those fetal red blood cells. Generally, this does not affect the pregnancy during the time that the pregnant person was exposed to the fetal red blood cells because the fetus is delivered before the pregnant person's body has time to produce those anti-D antibodies. However, those anti-D antibodies persist for life and can cross the placenta. And so this is where exposure becomes concerning because it puts any future pregnancies with an Rh positive fetus at risk for such things as hemolytic disease of the newborn, which is when these antibodies lead to breakdown of the fetus's red blood cells, or other issues like that, leading to, it can be intrauterine death of your baby in the worst case scenario.
So why is this important? Rh incompatibility, meaning an Rh negative pregnant person with an Rh positive fetus, happens in about 276 out of 100,000 live births worldwide. And we know that, like Dr. Alicia said, 50% of untreated babies can potentially die or develop significant brain damage because the red blood cells is how your growing baby transports oxygen to their growing organs. Now, the prevalence of this disease is much lower in developed countries because we have very good prenatal care. And so we see about 2.5 per 100,000 live births. Complications that can result from alloimmunization, meaning a pregnant person building antibodies against the fetus's Rh positive antigens, include miscarriage, something called erythroblastosis fetalis, which is where the red blood cells are being broken down and the baby develops significant anemia, significant low red blood cells. It can also cause hypoxia, meaning low oxygen. It can cause a delay in pulmonary maturation, meaning that the fetus's lungs are not developed as expected. It can lead to cardiac and heart failure. It can also lead to hydrops fetalis, which is very significant edema throughout the baby's entire body. It can lead to hyperbilirubinemia, which is high bilirubin or jaundice, and late anemia of infancy. Now, these are all big words, and they all sound really scary, but we want you to know with appropriate screening that these things are very, 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 very rare.
Probably the most common complication we see of this is jaundice in the newborn, and that we measure very closely and we treat.
Yeah.
So that is reassuring.
It is really reassuring.
But we do want to prevent this. So how do we prevent this? An RhD blood type and antibody screen are done at the first prenatal visit and again at the 28 weeks. If the pregnant person is Rh positive, there is no risk of Rh incompatibility, regardless of the baby's blood type, because the pregnant person already has that antigen in her bloodstream. So they do not make antibodies because they do not consider it to be a foreign antigen. So we screen everybody for their blood type at the beginning of pregnancy. And if they are considered Rh positive, then we do not need to do anything about it.
Correct.
If they are considered Rh negative, then we would recommend treatment to prevent creation of those antibodies. And we do this about 28 weeks, or if, like Dr. Sarah stated, if there is bleeding prior to that, or any of those things that she had mentioned before that. And we do this by giving an immunoglobulin to the pregnant person through a shot. And it goes in and it sweeps up any of those antibodies that may have been created if there was like tiny little microbleeds for some reason.
So a common question we get, if the pregnant person is Rh negative, can they simply test the partner or the sperm donor for their Rh factor? And although you could argue yes, if paternity is certain, but believe it or not, this is not a common practice because non-paternity rates can range anywhere from 2 to 5%. And so the standard of care is simply, like Dr. Alicia said, to check blood type, and if you're Rh negative, to offer anti-D, Immuneglobulin.
The other thing that actually has come up in my practice with the pregnant person is you can be a very weakly Rh positive person. So sometimes you screen Rh positive and sometimes you screen Rh negative, and we don't know who that's going to be. So if the baby's biological parent, that is not the pregnant person, is one of those weak Rh positive, Rh negative person, if we screen them, they come back Rh negative, we can't be 100% sure. And this is such a significant thing for future pregnancies that, you know, we have an informed discussion. And if you really don't want to, that's fine. But we really, really recommend getting the immunoglobulin.
Yeah.
Hey, Sarah, do you know what I've never asked you? Did you take a prenatal course when you were pregnant?
We did. Even though I'm a maternity care provider, my husband and I thought it would be an important process for us to go through together.
That's so cute. It must have been so hard for you guys to coordinate your busy schedules, though.
Oh, tell me about it. I was a medical resident at the time, and he was working full-time. We really struggled to find a course that would fit our needs and ended up doing a semi-private course that still was challenging to schedule and quite expensive.
Wouldn't it have been nice for you guys to have access to an online course with evidence-based content that you could do from the comfort of your own home or on your own time at your own pace?
You're telling me if I had had access to something like our Pregnancy to Parenthood Prenatal Masterclass, it would have been a game changer.
And that's the big reason we put this course together, to provide parents with access to reliable, comprehensive prenatal education from the comfort of their own homes and the ability to watch it and re-watch it when and where they choose.
Plus, it's got so much great information about preparing for the fourth trimester, which I'll admit, I felt really unprepared for. We focus so much on labor and birth when we're pregnant without understanding how challenging breastfeeding in the fourth trimester can be.
I hear ya. And that's why we put together such a comprehensive module all about what to expect for the fourth trimester and for your newborn.
If any of you listeners are pregnant and thinking about a prenatal course, I may be biased, but I would 100% recommend our online course. Head on over to www.shefoundhealth.ca/masterclass to check it out.
We promise you won't be disappointed or your money back.
So, the important thing to know about the immunoglobulin is how it works. So it's called anti-D immunoglobulin. So it's an antibody that's typically given through an injection, and it enters into the pregnant person's circulation. And what it does is it binds to any fetal red blood cells that have a D antigen. And so what that does is, like Dr. Alicia said, it sweeps it up or basically blocks it from the pregnant person's immune system seeing, I'm doing quotations here, seeing the D antigen. So though it's present, it's got this immune globulin attached to it. So the pregnant person's body doesn't see it. And this is really exciting. It is given in the form of Winrow, which was developed in
Winnipeg, Canada, to Winnipeg, go Winnie Pooh.
So it's a sterile liquid, and it's prepared from pooled human plasma containing antibodies to the D antigen found on Rh-positive red cells. So it's really, really important to understand that although this is considered a blood product, many, many steps are taken to basically confirm that there will be no risk of viruses being transmitted through this injection. So they do multiple steps, including donor screening, they filter it, and they treat it with a solvent and a detergent. And it's really important to know that there have been no reports of infectious diseases ever transmitted by giving or getting Winrow in pregnancy.
Sorry, Sarah, did you say that there have been reports of Winrow causing infective diseases?
Zero.
Oh, zero. None. Thank you.
None.
Zero?
Zero.
Okay, so let's just be clear. This is a very safe blood product that we are giving.
So safe. So like Alicia sort of alluded to earlier, if there's bleeding in pregnancy, so this could be a miscarriage sort of beyond that 5 or 6 week mark. If there's an ectopic pregnancy, if you have an invasive procedure like chorionophilic sampling or
amniocentesis.
I couldn't think of the word, so I was poking at my belly. We typically give a lower dose of Winrow, about 120 micrograms, if that happens before 12 weeks, or 300 micrograms if it happens after 12 weeks. There are other reasons we would recommend Winrow, which include a molar pregnancy, amniocentesis, or chordocentesis. And chordocentesis is when you're doing a procedure that actually a needle passes through the pregnant person's abdomen and into the umbilical cord. We would also recommend it if there is any placental trauma or any disruption of that fetal-maternal interface. So abruption, blunt trauma to the abdomen, any of those procedures we talked about, or placenta previa with bleeding. And also if you are undergoing an external cephalic version. So that's for people who are breech and we're trying to help flip your baby into hand down. If you're Rh negative, they would recommend giving Winrow because there's an off chance that there will be a disruption of that circulation between the fetus and the pregnant person.
Yeah. What we do not need to do is with delivery, we don't necessarily need to give it in all circumstances. And the reason is because any pregnant person with an Rh negative delivery, we always take some blood from the cord, which is fetal blood, and we check it to see if baby is Rh positive or negative. If baby is Rh negative, then we don't need to give it. And we can tell that it's your baby because it just came out of you. So we can confirm it, unlike
Absolute certainty.
the paternity test.
Yeah.
And if baby is Rh positive, then we do give the Winrow or the Rh immunoglobulin to you after delivery. And we like to do that about within 72 hours of delivery.
Yeah. So basically what Alicia is saying, that I'll reiterate here, is that you don't need to have it at the onset of labor as long as you get it within the 72 hours. And we can check baby's blood type. And if they're negative, We just prevent giving you an unnecessary blood product that is zero risk anyways, but just one less poke you don't need to have.
Awesome. I think it's a bit of a complicated physiologic system, complicated now that we're saying it out loud here.
Yeah.
But it's a really important thing. And I can't reiterate enough that it can prevent such huge and devastating outcomes in future pregnancies. And it is such a safe procedure compared to so many other things that we do that we really, really feel it's important for all people to get screened, and for those pregnant people who are Rh negative to have a good discussion with your care provider, but really, really recognizing the risk versus reward ratio of getting that Rh immunoglobulin. And I know blood products can sound very scary, but like we reiterated multiple times, it's very safe, very, very safe. So thank you so much for listening to this. We really hope that it wasn't too confusing and that you got a little bit of information out of it.
Yeah. Yeah. One thing we'll add is that in this podcast, we're not actually going to get into the specifics of how to manage a pregnancy to a person who has antibodies present. But just so that you know, it is considered a high-risk pregnancy because we know that fetus has a possibility of going on to develop anemia from those antibodies breaking down fetal red blood cells. And so it means a lot of visits and a lot of ultrasounds to look at how fast the baby's blood is flowing. And that's the way we monitor the fetus's sort of level of anemia. So they're really closely monitored, and it can involve a fetal blood transfusion. So meaning that cordo that needled through the abdomen into the belly to try and give baby a blood transfusion in utero. So like Alicia said, it's a very high reward, low risk for that pregnant person just to get that Winrow, which has never had any evidence of infectious disease transmission that can prevent a lot of really devastating outcomes.
So we hope that this uplifting podcast you've learned something about that you didn't know before.
Mm-hmm.
And we look forward to seeing you next time.
Thanks for listening, guys.
Thanks for listening. Make sure to check out our website at www.shefoundhealth.ca and to sign up for our community for weekly bump blasts. Make sure to check us out on Instagram or Facebook at she.found.motherhood and head on over to your favorite podcast app and leave a review and a 5-star rating. If you enjoyed this podcast, take a pic of yourself listening to it and share it on social. Make sure to tag us on it so we know to keep making them.